Hello, and welcome to today's webcast titled Calprotectin and the Diagnosis of Inflammatory Bowel Disease. My name is Sarah Berger with Meridian Bioscience, and I will be your moderator for today's event. During the presentation, you will be able to submit questions. Please click the green Q&A icon in the lower left-hand corner of your screen, type your question in the open area, and click Submit. Questions will be answered at the end of the presentation in the order that they are received. A few housekeeping notes we would like to mention before we get started. If you would like to view the presentation in a full screen view, click the full screen button in the lower right-hand corner of your screen. Press the Escape key on your keyboard to return to your original view. For best results in viewing this presentation, we suggest you turn off pop-up blockers and disable instant messaging programs to improve computer performance. If you are experiencing any difficulty with the audio portion of this webcast, we recommend using a wired high-speed internet connection, as wireless connections can be unpredictable. And finally, should you need any technical assistance, as a best practice, we suggest you first refresh your browser. If that does not resolve the issue, please click the Support option in the upper right-hand corner of your screen for online troubleshooting. It is now my pleasure to introduce today's program, Calprotectin and the Diagnosis of Inflammatory Bowel Disease. Inflammatory bowel disease, also known as IBD, is a chronic inflammatory disease of the gut, which presents with periods of inflammatory activity, or flares, and quiescent phases, or remission, as can be seen in many chronic diseases. IBD includes several different diseases. The two most important ones are ulcerative colitis, also known as UC, with the inflammation localized mostly in the colon, and Crohn's disease, also known as CD, which affects the entire gastrointestinal tract. The highest reported prevalence of IBD is in Europe. For UC, it's 505 per 100,000 persons. For CD, it's 322 per 100,000 persons. And in North America, for UC, it's 249 per 100,000 persons. And for CD, it's 319 per 100,000 persons, and affects people of all ethnicities. IBD is believed to be associated with the industrialization of nations, and the incidence may be rising in developing nations as they become more industrialized. Given the high prevalence of gastrointestinal disease, the value of calprotectin in IBD patient diagnosis, and the downfalls of traditional treatment pathways, it is clear that calprotectin testing is beneficial to patient care. I would now like to introduce today's speaker. Dr. Arne Roth is a U.S.-Norwegian gastroenterologist with more than 25 years of practical experience in the use of calprotectin, and one of the global key opinion leaders for the application of this novel biomarker. He produced the very first study and publication on calprotectin and has numerous publications to date. Currently, Dr. Roseth is a gastroenterologist at Lovisenberg Hospital, Oslo in Norway, and continues to be an excellent resource on this topic. And at this time, it is my pleasure to turn today's program over to our presenter, Dr. Arne Roseth.
My name is Arne Roseth. I am a gastroenterologist working in Norway. I'm also called the Calprotectin guy, and I will take you through the history of calprotectin, how it was developed, and I will take you all through some of the applications of this quite intriguing, fascinating molecule. But first, I will tell you a little bit about myself. I'm born in San Diego, so I have dual citizenship. I'm a U.S. citizen, and I'm also a Norwegian citizen. I was raised in Norway, and then I went back to San Diego for my pre-med training at San Diego State. And then I went back and finished my MD in Norway. Later on, I also did my PhD dissertation on calprotectin as a marker of IBD. I'm also board-certified gastroenterologist in Pennsylvania, where I worked for a couple of years, about 10 years ago. Okay, how did it all get started? Well, I started my career to become a gastroenterologist, and I was walking around on the ward together with the professor, and I was so intrigued that he could, by just asking a few questions, find out if IBD patients had active disease or no active disease. So I started to ask him questions, and he said, well, we have these indices. We have a Crohn's disease activity index, and we have the ulcerative colitis activity index. So then I was still impressed, and I started to read up on these indices. And then I started to ask some more intriguing questions to my professor, and I said, well, how do you know that these indices are valid? Because what I couldn't find in the literature at the library was that they were compared to endoscopy and histology. And one day he got really annoyed, and he said, Arnie, next week you can take Monday and Tuesday off, and you present a paper for our staff meeting on Friday on disease activity in IBD. So I did. I did the presentation, and the professor liked the presentation. But what I found was that these indices had not been really validated. But I also found that a study from Australia, they had tested alpha-1 antitrypsin in stools and compared it to histology and endoscopy, and found that this was a quite interesting market. My contract was coming up for renegotiation, and I figured that, well, if I have an assay, I have a job. So I suggested to the professor that I should set up this assay, and he was quite thrilled about the thought of doing that. The reason I took my chance was that I knew partly the guy that was Norwegian champion in alpha-1 antitrypsin, Dr. Fagerholm. It turned out he was a world champion in alpha-1 antitrypsin because the PI system of this protein was his PhD project. So I went down to his office and asked if he could help me to set up this assay. And, you know, he's like a 5-year-old on Christmas Eve, and he was quite thrilled about doing that. So I went back to my professor, and I got 2 more days off work. He would cover my patients. I collected stool samples from different patient groups, and then I went back to this other hospital, and we set up the alpha-1 antitrypsin assay. Then we had lunch, and we talked about IBD. And Dr. Fagerholm said, so, Arnie, it's really the neutrophils you're interested in. I said, yeah. He said, well, some years ago, I said the protein from neutrophils. You know, we have the afternoon open. We have the extracts. Shall we test the extracts, see if there's any calprotectin in there? And we did. And you know, your lab people, you know that when you are running an ELISA, if you're a little bit in a hurry, you shake the plate, and it goes faster. And he was standing by the window and mumbling, this is historical moment, this is historical moment. And you know, I heard about these eccentric professors. I thought he was one of them. And then he explained to me, because the whole plate turned yellow from alkaline phosphatase, that it was lots of calprotectin in the extracts. But we couldn't see any difference between the patients. So we diluted, we reran, we diluted, we reran. About 8, 9 o'clock in the evening, we had a plate where we could see clear wells, and we had a plate with yellow wells. And when I checked my cheat sheet, I could see that the yellow wells were patients with IBD, and the clear wells were typical internal medicine patients, strokes, heart attacks, minor things like that, but not IBD. So that day, in March 1987, we discovered that, yes, we can measure calprotectin in stool samples, and yes, we can differentiate IBD from non-IBD. That was a pretty good day. But it's more than 30 years ago, and since then, calprotectin has been part of my life. I usually say that I have 3 kids. I have my daughter that's 35. I have a son that is 31, and I have calprotectin that is 32. So let's look at this protein and talk a little bit about the biological characteristics. Calprotectin makes up 60% of the total protein in the cytosol fraction, neutrophils, and also macrophages. Just to give you an idea how much that is, there are more calprotectin in the neutrophil than hemoglobin in the red blood cell, so a huge amount. It's a heterodimeric protein made up by 2 heavy and 1 light polypeptide chain. It's 36 kilodalton, comparing to, for instance, albumin, which is about 50 kilodalton, so it's a small protein. Each strand by 2 calcium or zinc ions, and in the presence of 10 millimolar calcium, it resists enzymatic degradation. That's very, very important because in stools there's a lot of enzymes that can degrade proteins. It has antimicrobial activity. It kills bacteria and fungi. It belongs to the S100 protein family. And very interestingly, not that many years ago, it was demonstrated that it activates toll-like receptor 4, which is a major receptor regulating mucosal inflammation. Unfortunately for us, being in the laboratory medicine business, it's stable in stool for at least 3 days at room temperature. That means it can be sent from the patient to the laboratory by ordinary mail. Here you can see the tertiary structure of the calprotectin protein down here. Okay, let's go on. So let's start to talk about irritable bowel syndrome, or what we call IBS. And that can be really a diagnostic nut. There are no defined biomarkers for IBS, and it's defined by clinical features used what we call the Rome criteria, which means that at least 12 weeks or more, not need to be consecutive, during the last year, that patient experienced abdominal pain and discomfort and have 2 or 3 features. That means that it's relief with defecation, it's change in frequency of stool, and it change in the stool appearance. Not very specific markers here. And it's like Olympic rings, where you have irritable bowel syndrome, you have dyspepsia, you have carbohydrate intolerance. But we as gastroenterologists, we are really looking for the needle in the haystack, which is the IBD. And that's where we come in. So this is a study that came out of King's College in London many years ago. King's was the first hospital outside my own hospital to set up Calprotectin in their laboratory. And when this graph came on the fax, I couldn't really see the Calprotectin numbers. That was because it was black and white. Now I highlighted that in red. But they compared Calprotectin to SED-rate and to CRP for differentiate between IBS and IBD. And you know a rock curve, if you have a straight line, it doesn't differentiate between 2 entities. And the perfect the rock curve would look like this one. And you can see Calprotectin is way better to differentiate these 2 entities than the blood test CRP or SED-rate. This is, there have been lots of studies that have confirmed these data, but the area under the curve from this one is from Switzerland, is 0.91, which is in diagnostic view, very, very good. Usually the area under the curve will be 91 to 93%. That is a combination then of the specificity and the sensitivity, which is very, very good. So let's look at a case story here. This was a woman born in 1973. She had a 6-month history of diarrhea, abdominal pain, and no weight loss. So just diarrhea and abdominal pain would qualify for IBS. Her blood tests were perfect: normal hemoglobin, normal SED-rate, normal platelets, CRP of 0, normal albumin, normal electrolytes, liver kidney test, and vitamins. Now, Calprotectin was $13.95. So I did a colonoscopy, and what did we find? A severe active Crohn's disease in the lower part of the small intestine, what we call terminal ileum, which is a very common place for Crohn to be active. So what would have happened to this woman if we haven't done the Calprotectin test? Most likely she would have developed a stricture, which is because of connective tissue. Makes the lumen more and more narrow, and until it ends up in an emergency situation with an ileus. She probably also developed fistulas during that period of time, and she would need to have surgery. Fortunately, we got there before that happened. Okay, IBS, irritable bowel syndrome. it is a significant economic burden to the society. It affects approximately 12 to 15% of the population in Europe and in the United States. In India, it's up to 25%. That's probably why, because they have a lot of GI infections. About 40% of the IBD patients seek medical advice from their family doctor. That counts up 12% of all primary care consultations. And we know that about 40% of them are referred for colonoscopy. And that is also our impression when we do colonoscopy, that half of them are negative. The IBS patient has 3 times more absenteeism than from work. They have the cost of IBS is similar to asthma to the society. And the typical workload of a single patient, and this is old number from 2001, back then it was nearly $2,400, where colonoscopy was $1,600. And the cost of the American health system was $25 billion back in 2001. Okay. So then I found some data from Europe just to compare. There were a study from 8 European countries. When I looked it up on Wikipedia, that was 330 million people, just like in the United States. We beat the Americans with a cost that was determined to be $40 billion, and 1/3 was direct cost like colonoscopies. 2/3 were indirect costs. And this data is also pretty old, from 2006. So the numbers today will not be lower, but rather much higher. So if you can differentiate the patient with IBD from IBS, we can save big money for the society and insurance company. Okay, so calprotectin in the differentiation of IBD from IBS. When Billman submitted their ELISA for the FDA, there were 1 protocol, 3 testing labs, and 13 clinical sites to validate the fCal ELISA to differentiate IBD from IBS. And this was based on endoscopy and histology, which is, in my opinion, the only way to go. In that study, they found that an fCal value below 80 had a negative predictive value of 91% to exclude IBD, and but the positive predictive value was only about 67%. However, raising the cutoff to 160 only reduced the negative predictive value by 7%, but increased the predictive value to 85%, which is very important to keep the amount of false positive as low as possible. This is a very important message and has been validated in lots of studies using the Billman assay in Europe, including my own studies. So the bottom line for me will then be, show me the physician that dare to give anybody an IBS diagnosis without first testing for calprotectin, because this can delay diagnosis of IBD, and which can result in complications like strictures, fistulas, colectomy, and not to forget increased risk of colorectal cancer, especially in patients with ulcerative colitis. There are some, not many, but there are a few head-to-head studies that compare the Billman calprotectin kit to the competitor, which is a polyclonal antibody kit. And here you can see on the ROC curve, the ROC curve for Billman is much better than the ROC curve for the polyclonal kit, with area under the curve of 0.94 versus 0.86. And what does this mean? Well, this is data from my own clinic, where you can see here on the column to the left, mucosal healing. That is, if you do endoscopy on a patient with IBD, the mucosa looks normal. The red numbers is the polyclonal kit. The blue one is Billman. Here the kits perform pretty equal. If you go all the way to the right side, during active disease, it's still they perform fairly decent, except for these 2 false negative in the polyclonal kit. But look here, with low activity to moderate activity, this is where we do medical decision making in these patients. The polyclonal kits reach way too low to be actually useful in determining disease activity in these patients. And this is where the advantage for the monoclonal kit comes in, where I can then determine that there is subclinical inflammation in this patient. I can do dose increase of drugs, or I can add drugs to treat the patients before they get clinical symptoms with 20 bowel movements a day, bloody stools, fever, anemia, weight loss, and the whole shebang. This is very, very important to improve the quality of life in these patients. Here's another study, also using the Billman ELISA, comparing to a manufacturer X extended range. And again, the sensitivity for the Billman kit was at 80 was 96%, whereas it's 86% for the manufacturer X assay. And what does that mean? It means at least 9 pure false negative patients in out of these about 110 patients. This is very important. And you can see here the Billman is the blue curve versus the green curve. Why is it like this? Well, we have a different hypothesis for that. I think one of the important things is that the monoclonal antibody used in the Billman kit recognizes a epitope of a combined epitope of a complete native calprotectin protein, whereas the competitors they use a recombinant protein in their ELISA, and I think probably that is a disadvantage and gives a less specific assay and less and not as sensitive assay as we do have. Okay, let's go to another case story. This one is quite cute. 32-year-old woman, many years of abdominal pain and diarrhea. She was referred for colonoscopy in July, and that was the middle of some vacation in Norway. Very difficult to have a colonoscopy. And her family doc had done Calprotectin, and it was higher than 1,800. So I called her in the morning. I said, you know what? I can scope you tomorrow. I have an opening. And the patient said, it's kind of inconvenient because I'm on the airport express train going to the Canary Islands on vacation. And I said, you are? Are you not ill? And the patient said, no, it's just my IBS. I've had IBS since I was 16 years old. She called me from the Canaries. I said, yeah, I've been thinking, could I have a colonoscopy when I come home? So I scoped her after about a couple of weeks. She had massive Crohn's disease, deep longitudinal ulcers. I put her on a drug called methotrexate, 25 milligrams PO once a week. After 3 weeks, her Calprotectin was down to below 250, meaning mucosal healing. Interestingly, both her parents were physicians, and that kind of demonstrates to you how difficult it can be sometimes to differentiate the IBS from IBD. But this woman had, since she was 16 years old, finished high school, went to university, got a master's degree with untreated Crohn's disease. So let's look at some data. This is a study from Finland, from Sipponen, and she did everything correct. They did endoscopy during the follow-up of patients that were treated with infliximab. Infliximab is what we call a biological drug, and it's very, very effective in a lot of inflammatory disorders like rheumatoid arthritis, but also in inflammatory bowel disease. And on this graph, you can see that most of all the patients had Calprotectin higher than 1,000 before treatment. And then they did Calprotectin every 2 weeks, pretty much what I do. And you can see Calprotectin drops like a rock. This patient had a relapse, so got an extra dose before coming down here. And the correlation between the endoscopic index and the Calprotectin was 0.83, which is very, very, very good to be when you compare a biomarker with endoscopy. So it shows you beautifully how we can use this drug to monitor the effect of treatment in patients receiving biological treatment. This is another patient group. This is a patient with ulcerative colitis treated with 3.6 gram mesalant, or Lialda, you call it in the United States. And what I do is that when I have scoped them, I usually tell them before they go home that wait for 3 days, send me a stool test, and then you start your meds. So I have a very good information where the level of inflammation is when we start the drug. And you can see again, most of the patients are 1,000 microgram or higher with calprotectin. You can see again, they send me a stool test after 4 weeks and then 8 weeks. This patient didn't do very well, and it turned out that we tested her. She had C. diff on top of her UC, and so we treated her C. diff, and she went straight down here. And then I will usually see them out here at 10 weeks time. And I use then these graphs to show them how effective the drug is. And I think this is very important because people don't like to take drugs, but I can show them how effective it is. There's no side effects, so please stay on the treatment. And I think it helps me with regards to compliance and adherence to the treatment. And this is also a very, very important slide. I started to see normalization of calprotectin in patients with IBD. Back then, this is before turn of the century, we thought that you could not obtain mucosal healing in IBD back then. Turned out we were wrong. So I call the patient and I say, this is your friend, Dr. Arnie. Could I please do a colonoscopy because your calprotectin levels are so good? And they said, well, Arnie, you said I didn't need to do a colonoscopy as long as I send you the stool test. And I knew, yeah, I know I'm in trouble. But I'm going to give you plenty of sedation. And 45 patients volunteered for a colonoscopy. And what did we find? We found that all the patients had endoscopic healing, and 38 out of the 45 patients also had complete mucosal healing. That means the histology was normal. So that demonstrated to us that, yes, we can obtain mucosal healing in IBD patients, and we can measure that by using calprotectin, not only a colonoscopy. This was published back in 2004. So, how do I use this marker in my clinical practice? Well, as I said, they come to my office again, usually after about 8 or 10 weeks, unless something else has happened in between. And I tell them, now, you send me a stool test every 4 weeks. The numbers looks good. You now have mucosal healing. And if you then look at this graph here, now we're up here. And these are patients that, when they have obtained calprotectin below 250, they only have about a 10% chance of relapse during next year without any change of the medical treatment. So now you can send me a stool test every 3 months. And well, I don't like to send stool tests. Yeah, I know, it's kind of a dirty business, but I can set up for colonoscopy. No colonoscopy. I send them the stool test. And then I tell them, because the advantage is that if you send me a test and it's high, I will give you a call and say, your test is a little high. How do you feel? And they would say, I feel great. So send me a new test after a couple of weeks. If it's high, I call you. And if they are high, I tell them then that means you're on this track. That means that you will have, with nearly 100% sensitivity to specificity, a relapse within the next 12 months. But it won't happen tomorrow, but it will happen maybe 2, 3, 4 months down the road. That gives us a window of opportunity to change your medical treatment, to follow up, to see if it works, or we could add another drug, or if we're out here and nothing works, we could go biologic before you experience the down trip of active IBD. And they like the idea, and they send a stool test, and sometimes they call and say, I feel really upset in my stomach. They said, but your calprotectin levels are perfect. Oh, okay, so it's just my IBS problem, that it's just acting up. Because you have to remember, in patients with IBD, there's a lot of IBS problems, probably secondary to damages to the mucosa during the years of flares of IBD. And this is not only my own idea. Here's a study that came out a few years ago from, it was a big multicentre study in Europe, and they found that if they had 2 consecutive calprotectin levels higher than 300, I do 250, 300, that's semantics, collected 2 months apart, could predict relapse with 100% specificity. Okay, so why use calprotectin? Why not use CRP? It's a blood test, it's much easier, more convenient. This is a study from the United States presented some years ago, and more than 100 patients underwent ileocolonoscopy and also a small bowel follow-through. They found that clinically active Crohn's disease, about 50% had normal CRP levels. Endoscopic active Crohn's disease, about 50% had normal CRP. They found no correlation between histology and CRP, and they found no correlation between CRP and small intestinal disease, what we call ill disease activity. That means that it's not very useful. But why is it like this? Because we thought CRP is a good marker for inflammation and infection. Well, turns out the large variation in CRP response in all of us due to SNPs, single nucleotide polymorphisms. So there's another kid on the block. What about lactoferrin? Well, point one is that's a qualitative result. It is not as stable in stools as calprotectin, so it must be sent frozen from the patients or the hospital to the lab. And since it's qualitative, you cannot monitor patient disease activity or response to treatment. And if you Google it, you will find it's about now close to 1,500 calprotectin publications, versus about 360 for fecal calprotectin. And one key opinion leader at the DDW a few years ago said that let's forget lactoferrin, let's go calprotectin. And again, if you look at the ROC curve, this is a study that we looked that also looked at lactoferrin versus the Billman kit, and the lactoferrin doesn't perform even as good as the polyclonal calprotectin kits. I think that that's kind of demonstrates that we should not use lactoferrin. So where do we go? Well, this is a statement by Edward Louis, one of the key KOLs in Europe at the ECHO meeting in Barcelona 2012. He said, quote unquote, for the last decade or so, the mantra for the gastroenterologists have been to obtain mucosal healing. By the help of anti-TNF blockers, we know we can induce mucosal healing. We understand the importance of mucosal healing. Therefore, it's time to shift to a new mantra, tight control. So why should we aim for mucosal healing? Well, Gert de Hans, another KOL in Europe, did a study nearly 20 years ago, and he found out there was increased time to relapse in Crohn's disease patients with mucosal healing. And he stated back then endoscopic healing should probably become a standard treatment goal. Bitton out of Canada said that improved prognosis and time to relapse in patients with mucosal healing without infiltration of white cells, that being complete histological healing. And Gosh, that used to work also in Canada, found that patients with subclinical inflammation were at high risk for clinical relapse during 12 months follow-up if they had slight inflammatory activity. And again, what do we mean by mucosal healing? Again, Riley found that even if we had normal appearance or slight erythema of the mucosa, all the patient had chronic inflammatory infiltration. So, similar with Gestahans, with complete healing, disappearance of all endoscopic lesions, again, histologic healing in only 50% of the patient. And again, Bitton out of Canada found normal mucosal appearance or slight erythema, that 50% had infiltration of inflammatory cells in the mucosa. So the definition of endoscopic healing is still a little bit up in the air. In most studies, they use endoscopic healing, but personally, I think that maybe we should be more stringent to go with histologic healing, but that's a discussion we haven't finished yet. So what about the accuracy of the Billman kit to detect mucosal healing in patients with Crohn's disease? This is a very, very nice study out of Barcelona, presented some years ago. And if you see this green rock curve, area under the curve to detect mucosal healing with a cutoff as 258. You have to remember 258. It will be on the quiz later today. And then why should we have mucosal healing? This is a study published in Gastroenterology some years ago, that patients with Crohn's disease that obtain mucosal healing within the first year, about 16% would have surgery in 10 years versus 30% in the same time period if they did not have obtained mucosal healing. And again, same story goes for UC, again from Barcelona, You see this very nice rock curve, area under the curve, 0.94, pretty much like to separate IBS from IBD, but this is to separate active disease from inactive disease. And the cutoff was 245. You know what? The other one was what? 258, 245? Let's do it simple. Let's go 250. That's easy to remember. And that's what I use in my clinical practice. And again, why should we have mucosal healing in UC? Again, if they had mucosal healing within the first year of the diagnosis, they would have a colectomy, the colectomy risk would only be 3% versus 10% if they did not obtain mucosal healing in the first years. And a colectomy is not nice. And this is one of the last very big studies that just was recently published, the CALM study, the effect of tight control management of Crohn's disease, a multicentre randomized phase 3 study in Europe. The primary endpoint was endoscopic healing, and as you can see, those that were validated clinically, about 30% had endoscopic healing, versus those that were validated using endoscopy and calprotectin, about close to 50% had endoscopic healing. And furthermore, here you can see secondary endpoint was steroid-free remission, and in every aspect here, all the patients that were under tight control with calprotectin and endoscopy had much better secondary endpoint status at 11 weeks, 23, 35, and 48 weeks than those that were clinically validated. So tight control is the way to go, but we can't scope them all. So we need a substitute marker, and today calprotectin has been shown to be such a useful marker. And this CALM study finally also was used for the American College of Gastroenterology to state that the new UC activity index include calprotectin, and patient with remission should be below 150 to 200 microgram per gram stools. And again, mucosal healing as a target, that treatment of UC should be to try to obtain mucosal healing, and that calprotectin is a surrogate marker for endoscopy when endoscopy was not feasible. So, laboratory medicine, where do you fit in? Well, it turns out that 60% of all clinical medical decision making is based on lab results. And I also checked out the cost of laboratory medicine, at least in different countries in Europe, is only about 5% of the total hospital budget. So you're really the inexpensive part of the hospital. And calculations of potential saving use of calprotectin difference organic from functional gastrointestinal disorder in Sweden was about 20 million euros. So, we're small countries compared to the United States. We're talking billions. So in conclusion, calprotectin can save large amounts of money for the health system. It differentiates effectively between IBS and IBD, IBS, irritable bowel syndrome, and inflammatory bowel disease, and prevent misinterpreting, and this is very, very important, IBD for IBS. It correlates both in endoscopy and histology in IBD. It's a predictor of future relapse in IBD. That means that you can monitor your patient, you can go in and change the treatment before they have a clinical relapse. And for optimal clinical utility of calprotectin, clinicians must be aware that they ensure that best documented assays are being used in clinical practice. So that's where we come in. So the Billman calprotectin is for many gastroenterologists and clinical medicine in Europe regarded as the gold standard. A lot of the other competitors are trying to tune their kits into our kits. Again, I think one of the advantages is that we use a native protein in our assay, and with a monoclonal antibody recognizing a combined epitope of a native protein. You can see we have a very good standard curve from 30 to 1800, and it's more or less straight line in the important range from 100 to 1800. And we like to say that our assay is robust, it's validated, and not least, it's published. And most of these CRO labs now are using the Billman Calprotectin kits in their labs, commonly used by the pharma industry. So the within lab precision of our kit ranges from 3 to 9%, reproducibility 6 to 23%, dilution linearity is fantastic, and the spike recovery is very, very good. If you look at the dilution linearity, look at this graph here on the right-hand side, and we, when I'm having discussions with laboratory people, I say, yeah, do dilution linearity if you wonder what kit to use. And then when you do that in a polyclonal or polyclonal monoclonal kits, you will see very different results than from what you see here from the Billman kit. Again, this is a Levy-Jennings plot that shows you the stability of these kits over more than a 10-year period. There is no drift in the kits in this period. I usually say that you know, the Swiss, there are watchmakers, tick tock, but they never release anything before it's perfect. I think that's the strength of our assay. And there are very few head-to-head comparisons between assays. This is was published last year, showing on the left-hand side 3 different patients with UC, where the patient had relapse. You can see this is the relapse, and here the Billman kit was the only kit that would identify the relapse. Here, same here, the Billman kit identified the relapse. The fCal kit did fairly well, but the polyclonal kit from the immune diagnostic didn't identify that. Same here. We identified the relapses, whereas the other kits didn't. And again, this is in Crohn's disease, similar results. Here are the relapse. Here, very little movement in the competitors' kits, because we have a very strong spike at each relapse, like you can see here, and also down here. So I think that wraps it up. I tried to give you an overview of Calprotectin, a little bit of the background history, how it has developed, and how it's now being received on both sides of the Atlantic. It's now also in the ECHO guidelines. It's now in the American College of Gastroenterology's guidelines to use for monitoring disease activity. So I wish you good luck, and thank you.
Thank you, Dr. Roseth, for a very informative presentation. It is now time for our question and answer session. If you would like a question to be answered, please feel free to click the Q&A button on the lower left-hand corner of your screen. Type your question in the open area and click Ask to submit. So our first question is for Dr. Roseth. What is the reason for the change in cutoff ranges from 50 to 80? Could you please explain the cutoff value in terms of what this means? For example, a patient who has been running around 110.
Okay, then we have to go back to many years go back when I did my first study with all the flaws that was back then. But we introduced the cutoff of 50 back in the 90s. That was a polyclonal kit. Now with the monoclonal kit, it reads higher. So we defined 80 as a cutoff when we did the FDA studies. Now, in my clinical practice, I tend to put it a little higher because there is a gray zone. And a lot of people ask me this question, what do you mean by a gray zone? I say, well, let's look at CRP, because people have been using CRP for 20 years. Cutoff of CRP is usually from 5 to 10, depending a little bit on the assay. But nobody would look for pneumonia, a CRP of 15, 20, or 30. You look for CRP levels at 70, 80, 120. It's the same with Calprotectin. And it's important, in my opinion, not to use a cutoff level that is too low, because that will introduce too many false positives, and that will upset the clinicians. So what I do if I have a patient that I think probably most likely has IBS, but a reading comes back maybe 110, 120, 130, and you should say, well, you know what, I think you have IBS, but here's another kit, and send this to me when you feel really sick. And then I will call you, and then we can go from there. And nearly always it will come back negative. It could have been an intercurrent infection and whatever during the period when they did the sampling. But also we know that Crohn's disease, they can go up and down without any treatment. And I have seen that also in patients that we can miss because they go into spontaneous remission. That's why I ask them to send a new test when they feel really ill. Did that answer the question?
Yes, thank you, Dr. Roseth. We have another question.
Okay.
Buhlmann uses a purified protein for calibrators instead of a recombinant protein like manufacturers use. Why is this better, and what are the advantages?
Yeah, I think we pointed out a little bit that a little earlier during the presentation. I think one of the advantages is that the native protein is a native protein, and since we also then have an antibody that recognizes the combined native protein, it gives us very high specificity and sensitivity. And then the question would be, when you use recombinants, how do you know it is that the tertiary complex is correct? Because the tertiary complex is developed intracellularly by the help of different ions but also the Golgi apparatus, but you don't have that available when you are using the recombinant proteins. So I think probably that can explain the difference of the performance of the kits.
Thank you, Dr. Roseth. We have another question. Buhlmann does not require mixing of the specimen prior to extraction, while other assays do. What is the reasoning for this?
Well, let me show you a slide. This is going back to the 80s and 90s when I did my methodological work. So what I did, I took stool collections from more than 50 patients, and I took a sample from each end of the stool portion, and then from the middle of the stool portion, and then I took the stools and I homogenized it, okay? And then I took out the fourth sample that I called the gold standard from homogenized stools, and there is no difference. That means that calprotectin is evenly distributed in stools, and that can be also explained because when people are looking for blood in the stool, the blood will usually be on the outside of the stool. But the calprotectin, when it comes into the gut lumen, it's in viable cells that can move. So it's pretty obvious that it will be evenly distributed in the stool. So that's why we don't have to do the mixing.
Thank you, Dr. Roseth. We do have time for just one more question. We do want to thank all of our listeners for submitting their questions, and we'll reach out if your question was not answered today during the broadcast. So our last question for the day is, what does the workflow look like for laboratories who have implemented Turbo? How have they been able to handle stool processes from microbiology to chemistry? Are there any concerns with contamination on the open channel?
That's a very good question, and we can answer that by looking at what happened in Europe, that there's more than 120 labs are now using this on their big machines, and contamination has not been an issue. And when you look at calprotectin, when it's being diluted the way it is before it goes into the machine, it is less bacteria and less contamination than in urine. So it is not an issue.
Thank you, Dr. Roseth, again for a very informative presentation.